will address innovative programs to help improve your health system's HCAHPS scores. I'm Pam Andrus and will serve as the moderator for this discussion. The webinar is scheduled to last approximately 45 minutes with Q&A immediately following. All participants will be on mute, so please type in your questions and we'll answer them at the conclusion of the presentation. For more information on CompleteRx, along with upcoming webinars and events, please visit the CompleteRx.com website. It's my pleasure to introduce our speaker, Dr. Sandra Gregg. Sandy leads the day-to-day pharmacy operations for Roane Medical Center in Harriman, Tennessee. Her 25 years in management include experience in a variety of settings, from small rural to multi-system academic facilities. Dr. Gregg thrives in project management roles and has successfully implemented a wide range of initiatives that have significantly impacted both the culture and bottom line at Roane Medical Center. One being the Prescription Assistance Program, which provides over $300,000 annually in free prescriptions to Roane County indigent residents. She's also presented on the topic of performance improvement at both ASHP Midyear and the Tennessee Pharmacists Association. Most recently, Sandy and her team were recognized with the 2014 CompleteRx Patient Care and Complete Pharmacy Award. I'll now turn it over to Dr. Sandra Gregg.
Pam, thank you very much. And good afternoon, everyone. Thank you so much for joining me today. I'm very excited to share with you some pioneering experiences that show that the Roane Medical Center Pharmacy has been willing to go where no other pharmacy has ever gone before in bettering HCAHPS. I'd like to start off today by introducing our hospital. I'm very proud to show you our new facility, which we moved into in February of 2013. We are a 54-bed community hospital located in Harriman, Tennessee, just outside of Knoxville. We are proud to be part of one of the leading health systems in our area, Covenant Health. Covenant Health consists of 9 acute care facilities ranging in bed size from 50 to over 500. Covenant Health partnered several years ago to build a culture of customer service utilizing many of the tools of hardwiring excellence outlined by Clint Studer. You will see some of those principles that have been applied in my presentation today. In 2005, I assumed the role of Director of Pharmacy at Roane as an employee of CompleteRx. CompleteRx is a pharmacy management and consulting company located in Houston, Texas. Our mission is to enable our client partners to deliver optimal patient care by designing and implementing safe, cost-effective, and compliant medication use processes and systems. We achieve these results through operational excellence teamwork and by providing exceptional customer service. As a result, we pride ourselves in being a partner with Covenant Health, working together for patient safety and quality. In the presentation today, we want to accomplish a few goals. The first is to find opportunities for improving HCAHPS. Secondly, I will cover the strategies that we employ to implement these initiatives here. And lastly, I'd like to touch on the financial impact that HCAHPS have on all of our facilities. At this time, we'd like to start the presentation with a poll question. And I'd like to ask each of you, does your pharmacy actively engage in patient experience or HCAHPS initiatives? If you'll just answer yes or no, we'll review those results in a moment. Well, it looks like that about 25% of our audience at this time does not. And so for those of you who are already doing that, hopefully we can give you a few pointers that might be helpful. And for those of you who haven't started at this point, then maybe we can give you a place to start. As we begin, I want to quickly review value-based purchasing. CMS states that this program attaches value-based purchasing to the payment system that accounts for the largest share of Medicare spending, affecting payment for inpatient stays in over 3,500 hospitals across the country. The program penalizes or rewards hospital systems based upon two things: core measures and HCAHPS scores. And of course, the ultimate goal is to reward hospitals for improving patient care and safety. In 1966, did we think that we would ever be able to communicate on a handheld device without cords, as seen in this popular TV series? Well, today in 2015, each and every one of us uses such a device on a continual basis daily. In that same vein of thinking, did we ever think that the pill counters would ever play a significant role in impacting HCAHPS? Well, at Rome Medical Center, we accepted the challenge of the next generation, and we pioneered a program. We chose to boldly go where no hospital pharmacy has ever gone before. The journey began a little more than 2 years ago for us. I was sitting in a meeting at my facility where we were discussing our less than stellar HCAHPS scores. The meeting was primarily focused on how can nursing make changes to improve. As I sat and listened, I began thinking, teamwork always leads to better results. So how can I, as manager of the pharmacy, identify areas that we can step up and take ownership in HCAHPS? The first was pain management. I volunteered to design a program where our pharmacists actually visit each patient to help assess pain, to teach about the pain medications, and to work as a team with the physician to design the best plan for pain management. In a moment, I'll share with you the detail of how we launched and now manage this service. As our first program took shape and we began to see results, I began looking for additional opportunities for my department to take on more HCAHPS ownership. So we selected the category of responsiveness of staff, or answering call buttons. So why should only the nursing staff be responsible for answering call lights? I will show you today how pharmacy and other ancillary departments joined these ranks. Well, we had 2 programs up and running, so why not go for the trifecta? And the most obvious one for us was communication about medications. Pharmacists are the drug experts, so I felt that it was important that we step up and embrace this ownership. So where do we start? First of all, you must have a vision that is realistic. If you asked my pharmacists in the beginning if any of these initiatives were realistic, I am sure they would have told you I was crazy. So as I worked on the development, I had to rearrange workflow to actually make them realistic. I had to fit these new duties into our daily routine without jeopardizing patient care. The vision also had to be measurable. In the development of any new program, it is important to know where you started, to set your goal, and to measure results on an ongoing basis. So how do you get buy-in from a small staff to take on more work? Well, you must instill the passion and the ownership in your staff, and that started with me. I had to let my staff see and feel my vision, not just once, but over and over. I had to challenge, re-challenge, praise, and reinforce the goal. So we set monthly goals and we reviewed them at least weekly, and I advanced them somewhat insidiously. We acknowledged our progress weekly and we reemphasized our goals. We inserted ongoing recognition by posting flyers of encouragement, sending thank you cards, and posting metrics and scores. We made it into a fun and friendly competition by offering prizes to top performers and public acknowledgement of each employee's participation. I constantly monitored each employee's response and buy-in. People are motivated in different ways. I could see clearly that some of my folks weren't motivated by free movie tickets. So I made it a permanent element of their performance evaluation. And this was the final step in hardwiring some of these processes. The first and the most difficult area that we chose to tackle was pain management. We actually started this program over 2 years ago with the initiation of daily pain consultations by pharmacists. It was slow and hard to maintain. We have had to constantly change our strategies and processes to affect consistent results. We set our initial goal to reach 80% of inpatient admissions. We felt that this was realistic. We then identified patients for exclusion at that time, and those were ICU patients, patients with advanced dementia, and unresponsive patients such as ventilator patients. And a funny one that I discovered was that the staff did on their own was to avoid patients and contact precautions. A scripted consult guide was developed to ensure continuity of information, and we used the Studer-aided approach. Well, a new process is not without challenges. And earlier in my presentation, I mentioned that my staff thought I was crazy and beginning to think that we had time to visit every patient in our facility to conduct a pain consult. I have some of the best team-playing pharmacists that you could ever have, but initially they were very stressed about the thought going to the floor and making this happen. Some of them were very uncomfortable in talking with patients. So here are a few of their valid reasons why. Number one, we're a very small staff. So how do I, as the bench pharmacist, take time away from order processing to go talk to patients up on the floor? Secondly, we are not a 24-hour pharmacy, so we're playing catch-up between 5 p.m. and 7 a.m. for that activity. And this was the hardest one. Pain is very subjective. Oftentimes, patients have the expectation that pain management means no pain. And then lastly, drug seekers, people who are on chronic pain medications, and even real addicts, they never have enough pain medication. Because my pharmacist has varied personalities and varied patient focus, we felt it was important to develop a script to be used as a template for our patient conversations. I used the example to my staff of the fast food chain who takes your drive-thru order saying, "Good morning, my name is Susie. How may I serve you?" They also end their encounter at the window with, "It was my pleasure." Wow, doesn't that sound better than "take your order"? That sort of scripting helps to define a culture of service that you can expect on every encounter. It was important to me that I know that every patient encounter flows in a similar fashion, regardless of which pharmacist was doing the consult. So we designed this script. This script starts with the AIDIT method that Clint Suter utilizes in his work on hardwiring excellence. So I'm going to go through in detail what that means. The A stands for acknowledging the patient. "Good morning, Mrs. Jones." The I stands for introduce yourself and identifying why you have the expertise to discuss pain meds. For example, "Hello, my name is Sandy, and I have been a hospital pharmacist for over 20 years. The D is for the duration. Define the time you're going to spend with the patient. It is important for the patient to know it won't be a lengthy ordeal, and it also helps the patient know you will only be there a few moments. Because frankly, some patients just want conversation, and this helps with preserving the pharmacist's time allocation. The E is to explain why you're there. I might say, "I want to discuss your pain control today. Sometimes we can't make your pain go away completely, but I want to be sure we are keeping it at a manageable level." The T stands for to thank the patient for their time and to ask them if there's anything else that you can do for them. In order to ensure that the presentations consistently portray effective communications, I personally accompany each person on a consult once a month to observe, to critique, and to coach. After the initiation of our pain consults, we monitored our metrics for 3 things: the number of consults, normalizing those against our number of admissions. We looked at reasons why consults were not being completed, and of course, we watched the trend of pain management on our HCAHPS scores. Then we made modifications. Based on our findings, we expanded our scope of service in order to reach more patients. We included all inpatient admissions. If a patient was unable to interact, the information was shared with the family or the caregiver. And patients in contact precautions, well, those pharmacists now gown up and they go in and we do them. We expanded our consultative services to weekends. We re-engineered our daily workflow in order to perform consults earlier in the day to avoid discharges without consults. We changed the scripting to include verbiage around teamwork with nurses and physicians. We facilitated follow-up with nursing and physicians on other discovered issues. Sometimes during the patient exchange, we might find other areas where we can intervene. Maybe the patient is nauseated, so we contact the physician to obtain an order for an anti-nausea agent. And then we utilize the med-rec nurse for assistance in preparing our teaching materials, and I'll talk in more detail about that in a moment. Then we changed our written information from lengthy papers into easy-to-read, brightly colored cards. It took some time, but here are our results. As you can see, we started out doing approximately 50 consults per month, and now we are doing over 150. This graph shows that daily pain consults have gone from being something we tried to work into our day to a function that has the same priority as drug distribution. As you look at our actual HCAHPS scores, you will see that our progress has been slow in this area, but we're moving in the right direction. As I've spoken earlier, you must constantly analyze the trends and make process adjustments. We want to see our trend of success climb higher. So we've identified our next focus, and that will be how we can better manage or reach our patients who are on chronic pain medications. So stay tuned. We have a plan. Let's talk about our second initiative, and that is responsiveness of staff, or call-outs. And this one has really been a lot of fun for us. So what is the no-pass zone? Quint Studer Group says, creating a no-pass zone involves training everyone, and we mean everyone, on staff to respond to a call-out. Every staff member is not capable of assisting the patient with all needs, but they can promptly respond and triage the need to the appropriate patient. Imagine being a patient in a hospital bed. You've had surgery and you're in pain. You may need to go to the restroom, or maybe you just need your reading glasses or help with the TV. So you push your call-out button. You're lying there watching person after person pass by your room, and no one comes in to help you. Finally, after what seems like an eternity, a harried, busy nurse runs in and brusquely asks you, "What do you need?" How do you feel right now? At our facility, maybe a year and a half ago, our leaders showed us a powerful video of this very scenario as I just described to you. We were all encouraged to get involved in answering call-outs, but at that time, no goals were set and no method of measurement was identified. So as part of the HCAHPS team, the pharmacy identified a way to stimulate involvement of ancillary areas and how to measure the progress. The no-pass zone ticket was born. We had these pocket-sized tickets printed that capture the metrics that we want to measure. At the beginning of each day, the employee puts a supply of the cards in their pocket and heads about their work. When they are on the floor and they answer a call-out, they document the information on the card and place it in a bin in the pharmacy. Pharmacy's creation of no-pass zone tickets did three things. Number one, we captured the employee participation in a fast and easy way. Number two, we identified trends in patient needs that led to other possibilities for patient care improvement. And last week, we decreased demands on nursing. Many requests could be completed immediately without notifying the nurse, and such as thermostat adjustment, TV or phone assistance. And in the interest of patient safety, we did do trainings at a quarterly employee forum that distinctly identified tasks that were acceptable for non-clinical employees. Accountability is a must in starting a new program. And Covenant Leadership now requires monthly posting of no-pass zone metrics on our corporate SharePoint. Metrics are kept on specific patient needs. Other areas of customer service or safety have been identified and followed up on. Monthly goals are increased. We want to keep the employees stretching for that goal. And staff recognition, this is where we've had a lot of fun. And we award the top performers. We use some things we call star cards, which are scratch-off tickets that yield prizes of desserts and beverages from the cafeteria. We also use free movie tickets, treats, cupcakes, candy. We have celebration luncheons. And then we name our participants on our department bulletin boards and also in the hospital monthly newsletter. And personal handwritten thank you cards are mailed to the employees at home. The sustainability of a new project is always a challenge. We are asking an employee to continuously go above and beyond. One thing that I do on a weekly basis is post a catchy flyer on our no-pass zone board that tells where we are on that day and reminds them of the monthly goal. This slide is an example of one of those flyers. As you can see, it says that we have achieved 80 no-pass zone cards as of today, but our goal is 100. So we tell the patients, the employees, to keep going, and you can do this. Also, we have a poster where each employee documents their daily number of completed cards. This visual of coworkers' success stimulates some healthy competition. So, were we successful? I believe this chart shows the results. As you can see, the pharmacy was the first department that started using the No Pass Zone cards last July. As the graph shows, gradually the participation from other ancillary departments expanded, and each month the numbers grew. By achieving buy-in from other ancillary departments, we have been able to answer up to 400 call lights for nursing. This slide also shows that the departments that spend the most time on the nursing floor, such as respiratory therapy, have the greatest opportunity for assistance. For departments that do not spend as much time in patient care areas, we encourage no pass zone rounding in between those assigned times. Medication information. This category, this is our most recent addition to our team approach to HCAHPS improvements, and we launched this again last July. Prior to that time, the task of communicating information to patients about their meds had rested solely with the nurse. As we all know, nurses have many tasks that make up patient care, and most could seem much more critical than talking about medications. So why not have the drug experts take on this task? We did. As we know, Joint Commission requires us to give the patient information about all new medications that they receive. That's a tough task, so how do you do it? One of our system hospitals developed drug cards based on drug classes. So we had the cards, but how do we disseminate them to each patient for each new drug? At Roan, we utilize our MedRec nurse to daily review a report that shows new meds started, and she pulls the cards each day. The cards are personally delivered and discussed by her or by a pharmacist. Well, with any system or new program, we always want to keep it simple. These cards are written at a 6th grade reading level. They are brightly colored and contain our corporate logo. In the next slide, I'll show you an actual picture. The HCAHPS scoring for communication and medication information has two facets: medication explanation and side effects. When I share our actual results in a moment, I will point out the importance of not only disseminating the information, but having a specific focus on side effects. Before we distribute our cards, we highlight the effects and spend considerable time with the patient discussing them. We feel that it is very important to give tangible reminders to the patients to take home. The cards are delivered in professional-looking envelopes and are labeled with the patient's name. Weekly medication organizers with hospital names are also given to the patient at the end of the consult. Here is the example that I told you about. This is the front of our card, and on the back of the card we have the side effects listed, and we do highlight those. We have found that our level of success is directly proportional to the tangible things that we leave for the patient. When we go in to discuss medication information with the patient, they very likely are not feeling well. They may be under the influence of medications for pain, and they may be drowsy, or they may be out of the room getting a procedure done. So we developed this informational sheet that accompanies the medication cards. It reinforces in writing our hospital's focus on the understanding of medications. It also reinforces the importance of recognizing side effects. And as you see, we have italicized this in blue. Remember, this is one of the elements that creates the HCAHPS scores in this category. Also, if the patient is not in the room when we go in to visit, we do try again to speak to them in person. But if that's not possible, we leave this sheet with the medication cards. This graph shows the incredible success that we have had. We started at the very end of July, and you can see by the end of December that we were distributing nearly 1,500 drug information cards per month. Based on an average monthly number of admissions of 280, that equated to an average of 6 cards per patient. In a moment, I will show you our before and after HCAHPS, and you will see that this has been our most successful initiative. Remember, success is more than handing out cards. It is making a personal connection with the patient, thus promoting better patient care. At the beginning of this presentation, I identified 3 specific HCAHPS areas that pharmacy has targeted. So why are we going to talk about medication reconciliation? I'd like to introduce you to Mindy, our MedRec nurse. She's our HCAHPS glue. Most of you know that the addition of medication reconciliation technicians to hospital staffing is not really a new idea. Many large facilities have had them for quite some time. Roane Medical Center was the first Covenant small hospital to dedicate a full-time nurse to this important position. Oftentimes, success requires re-engineering existing processes, stepping out of that box. I often say, I don't even own a box. Most facilities our size have not had the luxury of instituting a MedRec tech. This task has been the responsibility of the nursing staff. Over a year ago, CompleteRx stepped up and offered to add a full-time position to the pharmacy to accommodate this important patient care function. Little did we know that we would be able to multitask this position into one that is an essential part of the success of our new HCAHPS initiative. A lot of careful consideration was put into the design of this position. First of all, we filled the position with an LPN with pharmacy technician experience. She kind of understands both sides of the fence. Interpersonal skills are extremely important. Our MedRec tech has an incredible bedside manner that is perceived by the patient as very genuine and caring, and she truly is. We established hours of service commensurate with admission trends in order to maximize the number of patients that the MedRec tech could address, so she works from 2 p.m. to 10 p.m. Monday through Friday. Nursing is responsible for doing MedRec when she is not there. We gave her additional duties to assist our pharmacist in obtaining our goals in pain management and communication regarding medication. She actually prepares our pain consult packets, and then she also pulls the new medication cards, and she actually visits the patients to discuss them. By not limiting this function to a pharmacist, we were able to impact many more patients. I want to share an actual quote that we received from a patient, and it says, "The cards the pharmacy comes in and gives are 100% perfect. I have never seen that done anywhere else, but everyone should use it." So now we'll review the part that you've all been waiting for, the actual results on the 3 areas that pharmacy has taken ownership of. The bracketed area of this slide shows you the first 7 months of 2014. The only program going on at that time was our pain management. And note, there's lots of red and there's very, very little blue and green. Now you're looking at the last 6 months of our progress. These results show a clear line of demarcation of when our 2 new programs started at the end of July. Looking at responsiveness of staff, we have no red. We have some green and some blue. These scores are still strongly driven by nursing. And even with our No Pass Zone project, ancillary services now answer only about 5% of total call-outs. So we still have lots of room for more out-of-the-box opportunities. The next one is communication about medication. It is all blue and green except for December. And if you look at that, the breakdown in the scores, you'll see that we scored in the 27th percentile on side effects. That was our wake-up call to refine our process and make process changes around patient awareness of side effects. You can see that our process changes immediately turned our scores around. Now let's look at pain management. As I mentioned, this has been our biggest challenge due to the subjective nature of pain. But we have not given up, and we have continually edited our processes and increased our number of consults. You can see the newest enhancements took place at the end of September, and we have sustained much better scores since then. Here are the fruits of our labors. Pain management, we have a 52% improvement from January 14 to January of 15. Responsiveness of staff, it does continue to be a tough challenge due to volumes. In 1 month alone, we have documented over 7,000 call-out requests, so more room to improve. Communication about meds, we realized an incredible 76% improvement during this year. In terms of providing a great patient experience, it can be really uncomfortable talking about money. But the facts are CMS has attached HCAHPS and core measures to the payment system that accounts for the largest share of Medicare spending, affecting payment for inpatient stays in over 3,500 hospitals across our country. Luckily, only a subtle uptick has been experienced with those receiving penalties from year 1 to year 2. In 2014, 1,451 hospitals received penalties under the value-based purchasing program versus 1,427 from a year ago, just a 1.7% increase. The bigger concern is a larger group appears to be falling into a negligible category of not receiving bonus or penalty. Roughly 1,200 hospitals will receive bonus payments for 2014, compared to 1,500 hospitals from a year ago, which is representing a 20.7% decrease. Regardless of how you feel about these changes in the CMS payment system, quality metrics are not going away, and patient assessments are largely viewed as a positive development by healthcare consumers. Not only does every patient deserve the best experience, they are now demanding it. New benefit and network designs are making the healthcare consumer more selective and cost-conscious. Public and private insurance exchanges are forcing consumers to be an active participant in the healthcare process and bringing price transparency to the market. Most importantly, consumers continue to be attracted to convenience and will reward great customer service with repeat business. So in summary, patient experience and health outcomes are truly linked. Making substantial, sustainable improvements in patient experience requires cultural change. HCAHPS must continually be analyzed and trended. The numbers are somewhat fickle and subjective, so we must hardwire our processes. We must continually take the elements that go into them apart and put them back together in another way. We must make our employees accountable, and we must praise them regularly. Healthcare regulations and reimbursement are constantly changing. We must never sit on our laurels. We must proactively anticipate. In anticipation of penalties for readmission, the Roane Medical Center Pharmacy has identified its next challenge, which is to develop a pharmacy-driven program that minimizes hospital readmissions. So stay tuned. It's not just a job to do. It has to be our passion, which becomes our culture. It is the next frontier. Thank you all very much.
Okay, thank you, Sandy. Before Sandy starts answering questions, we want to thank all of you for your participation today. The webinar with audio will be uploaded to the Knowledge Series section of the CompleteRx website, where you can download it at your convenience. Okay, our first question for Sandy is, what have your pain consults revealed as better opportunities for pain management?
That's been a great one. What we have noticed is that we typically are using a lot of every 2-hour injections, and so we have a working team with nursing that meets biweekly, and we are identifying a push for more PCA, and we feel like that's going to give patients steady state pain control and also eliminate some of the workload for the nursing staff.
Okay, Sandy, the second question is, how do you facilitate the transition for pain management from the hospital setting to the home setting?
Here at Roane, we have a daily patient care meeting, which I really love. It gives the pharmacists are there, and we're working with the nurses and the doctors, and they will tell us anticipated discharges, and we will look at their pain regimen, and we will oftentimes suggest the doctor to how to transition them from IV pain meds to PO, so that they'll be ready to go home.
Okay, and third question, are you thinking about applying any of these initiatives to patient discharge counseling?
Yes, actually that is our main focus this year. We feel like that is another great opportunity, and that hopefully, as I mentioned in the presentation, that we can actually impact readmissions by making sure that the patients clearly understand the meds that they're going to be taking at home.
All right, that concludes the questions. If anyone has anything else, oh, wait a minute, we have a couple more. I'm sorry.
Okay.
Okay. Is your HCAHPS data based on month of the patient interaction or when the survey was received?
I am not 100% of that, but I believe it is when the survey was received. Because they do move, I will tell you, as you all well know. We can look at them today and then tomorrow they move. So I believe it's when the survey is received.
Okay, and how do you deal with a chronic pain patient that never seems satisfied with his or her pain control?
That's a real toughie, and believe me, that's a large amount of our folks seem to fall into that category. That's that's the second big push that we have for this year, and what we're doing, again, we're doing a lot of teaching to let them know that pain doesn't mean it all goes away. And obviously, if you're in the hospital, almost always hand in hand goes pain with that hospital stay. So I don't have all the answers to that yet, but we're digging our heels in because that is really, really a challenge. But again, mostly we talk with them about pain management and not elimination of pain.
Okay, thank you, Sandy. We really appreciate it. If anyone has any additional questions, please email to the email address on the screen. And we thank you again for your participation and have a wonderful afternoon.